Thank you to Michael and Max for inviting me. I'm really delighted to be here. So I bring you greetings from San Diego. So today what I'd like to do is describe the approach that we use. I should back up and say I'm a health psychologist, which means that I have training as a clinical psychologist, and I specialize in behavioral medicine. And I've spent the last 20 years or more doing research in health behavior change. Recently, I've moved to the UC San Diego campus, and I'm an administrator there in health and well-being. But I'm still participating in research, so I'm going to tell you about a few of our studies. The diet study, which is a text messaging intervention for weight loss. SMART is a brand new clinical trial that we're starting to do mobile, social, and other applications to do weight loss among college students. And finally, a Facebook Connect project, which is just in semi-conceptual stage at this point. And then describe at the end some of the things that I see as focus areas for the future. So I'd like to acknowledge my primary research partners, who many of you may know, one or more of them, Kevin Patrick and Jim Salas. We've been research partners since 1990, a long time. And the program of research that we've developed over these years has gone through an evolution since that time, starting with print-based programs, to help physicians learn how to counsel their patients about exercise, moving to web-based interventions starting in about 1995, and then doing texting interventions, and now more social and mobile interventions. I also want to say, conflict of interest, this is the part where the university shames us and we have to confess our sins, that we have actually started a company to disseminate some of our research because none of our funding agencies were really interested in doing that. So I am a co-founder, along with Jim and Kevin, of a company called Santec, where we commercialize some of the things that I'm going to tell you about. So this is a shot of where the lab sits at UC San Diego. This is the Cal IT2 building, which is an engineering building. And I bring that up because it's very relevant that we are a group of clinicians working with a group of engineers. And it's been a wonderful multidisciplinary team to pull together. And this is only a partial list, actually, of all of the researchers that are collaborating on this group of studies. I wanted to show you our model. It starts with kind of genetic and biological factors, which are kind of the givens that we have. And we see the real contribution of behavioral and social factors contributing in some overlay to that. But we also pay strong attention to the environmental and ecological factors that go into that. And we see different systems applying to each of those. And so the interventions that we develop are things that are meant to kind of plug in to one of these areas, recognizing that we're just one cog in the wheel, just one piece of what is needed for real change to happen in our country. So I don't need to expand on the increasing use of all these devices. We are all very familiar with that. So instead, what I'll do is describe a little bit about our M-Diet study. The purpose of this study, it was a small kind of pilot study, a randomized trial, to look at a text messaging intervention for weight loss in community members. And it was just text messaging. There wasn't a phone component or a web component or emails or coaching, anything like that. It was just text messaging. And so people received messages. I won't describe the intervention in detail, but there is a publication, which you'll see in a minute. But they got feedback back. So what was different about this, especially since this was done in kind of the early 2000s, was that it wasn't just pushing messages out to people, but it was also requesting them to give us feedback. And it was part of an engine that had about 3,000 messages and 1,500 intervention rules in that algorithm to decide who got what message. And what we saw in the study is that for men who received the intervention in the solid line, they had a bigger decrease in weight, as well as the women also had a bigger decrease in weight. And overall, it was about 4.2 5-pound difference between the groups. So not a huge difference in weight loss, but it was statistically significant, and given the low cost of the intervention, this is something that could be easily scalable to be delivered to large populations and could have a real impact. And here's the reference for this publication. The SMART study is a social mobile approach to reduce weight. This is a brand new study that we're just launching now, and it is using multiple components, both social networks using Facebook, social media, mobile phone apps that are being developed in conjunction with some collaborators at Stanford, also the web, and it's focusing on young adults. And this is part of a collaborative group of studies at NIH looking at, called the Early Trials, looking at these issues among young adults and how we can prevent the increase of this as they age. So this just shows a model of the different components. So if this is the student, in our case, interacting with applications on their web phone. I'll describe them a little bit in a minute. There's a Facebook connection where we're actually delivering part of the intervention over Facebook, and text messaging, as well as some things that they can use for reference on their computer, although in our experience, our students aren't really on their computer that much, but they have reference tools there. And we're collaborating with James Fowler, who we're very fortunate to have at our university, and drawing on his work with his colleagues at Harvard, looking at the social connection. And one of the goals is to really learn a little bit about how these things form and how to intervene here. So we're using some of the lessons from that work. And the way that we're applying it is that this is, our intervention is kind of representing the middle. We are only intervening with this group. These are our participants. But what we're hoping to see through Facebook analysis is that we may be influencing not only these participants, but also their friends and friends of friends, the 3 degrees. So these are examples of some of the apps that we're developing, and to keep it fresh, the apps are being added routinely over the 2-year period of the intervention, and they're focusing on behavior change strategies that we know are effective. Our group has done a lot of research looking at which are the effective components of behavior change, and I would like to agree with the journalist this morning who was saying that it's the behavioral factors, because it is very much behavioral factors that contribute to it. And we're also drawing on, this is very reflective of things that you'll see in the Michie paper about the meta-analysis on which behavior change techniques are effective. So we're employing apps that are addressing these, starting with these factors. So now I'd like to move on and say something about the Facebook Connect study. This is an unfunded study that James Fowler and I are doing with our colleague Lucia, who runs a supercomputer center at UC San Diego, and her graduate student, her computer science graduate student, Myung. And the purpose of this study is a little bit more basic science when it comes to the social network. We are asking students for permission to do something which I myself would never do, which is to give us permission to monitor and analyze everything on their Facebook page. And when the student gives us permission to do that, it actually allows us to see anything that they've ever put on Facebook, including when they joined when they were 13 and now they're 19, and so that we can really start to learn more about how these social networks form on college campuses to create communities and how they evolve over time. And we're also, because we collect data at the university, I collect behavioral epidemiology data. Every other year, we have other behavioral health and other outcomes data. As a new administrator at a university, I'm having to think about things other than health outcomes. Thank you. I'm thinking about things related to graduation rates, a sense of belonging, racial tensions, things that impact their academic performance. And we'll be able to analyze how these social networks impact all of those factors for these students. And once we understand that, we can develop interventions that can be delivered there. And so I think one of the takeaways, not just for a young adult population, but for most, is that we need to go to where they are. And for us, that means really looking at where they're spending their time. And I'll say a little bit more about that in a minute. But some of the things that we're really concerned about on campuses, we see a very much an increasing rate of depression and suicidality among college students, and as I mentioned, some of these other factors as well. So now I want to focus on a couple general themes that I see for now and in the future, and I'd like to focus on the maintenance of behavior change. One is that the technology that we use, if we're going to employ a technology, that it really is becoming ubiquitous. And I won't belabor that because we've heard a lot of really interesting information about that already today. That the behavior change intervention and the components that it uses need to be relevant to the patient and or to the theoretical approach. And I say and or for the same reason that Vic Strecher did, which is that we need to have our interventions informed by theory, but in the end, it has to be something that's meaningful to the receiver of it. And if they don't see the meaning in the component, they won't use it. So we really need to be keeping the user in mind as we're developing things. Having a high degree of tailoring, for all the reasons that Vic Strecher said, is good for interventions. And we need to have continuous interventions. This idea that you go on a diet and then you go off your diet is not working for us. And one of the ways that we can increase the maintenance of behavior change is to think of a way to have ongoing interventions. I'm part of a trial that is a very large cardiovascular disease trial, and we're working with patients who are post-MI. It's definitely tertiary care, and it's me and about 100 cardiologists around the world. And just kind of thinking about how they position the behavioral component next to the medication and surgical components. I'm the only behavioral person on there, and they're giving a little bit of time for us to do behavior change with their patients, but not enough. So when I talk to this group of physicians who are wonderful, I ask them this question: well, would you ever, if somebody comes to you and they have high blood pressure, would you ever, recommend that they stop their blood pressure medicine? No, because the effect would go away. And it's, in my opinion, it's kind of the same way with these behavioral interventions. We should not be assuming that if we give them a little dose of something and then remove it, that they'll be able to continue that forever. So it can't be something that's really costly. It can't be something that's really involved. Ideally, we would like to see people internalize things and have more intrinsic rewards from what they're doing. And they will, and things can be attenuated, but we are dropping clients and patients off too soon, so we need to continue that a little bit longer, in my opinion. We need to connect it to their personal values, and we've heard some nice conversation about that today, about to their personal mission. I really like what you were saying about the VA system, and I think that this helps build rapport, and it helps to provide meaning to what you're discussing with your clients and patients. And then also to focus on flourishing. So it's fun at the end of the day to see so many of the same themes come up, and I think I'm in good company with the rest of you here. And finally, we really need to think about some of the environmental influences. And this could be things about their immediate environment. And I was really intrigued by the monitoring project that was going on and that sort of thing, but also the built environment. And if that's something that you're interested in, I would really recommend that you read some of Jim Salas's work, looking at walkable communities, building communities that are likely to sustain health, and all of the things about the environment. So I have a few special considerations I'd like to share with you. One is, in particular with technology, is the annoyance factor. I remember when we first got email, and I thought, oh, this is so cool, don't call me, email me, because that's what I'll see. And in our interventions, when we first started going to an email intervention, there was so much interest in it, I think because of the novelty, that it became something that people really attended to. But what we found in a lot of our email interventions, and what I fear we might find in some of our text messaging interventions, is that their interest tends to decline and wane as people become overwhelmed with information. I don't know about you, but I'm like burdened by the emails that I know are building up. Just even today. And it's bad when you get to the point where taking a vacation is it's punishing to take a vacation because you come back to such a lot of information that you need to manage. So when we're developing interventions, this is something that we need to keep in mind. Another thing that we haven't talked about today so far, but this is kind of a general thing, and I speak about this because I've had the fortune or misfortune to publish a paper about the negative effects of one of our intervention. And that was, we need to consider if there are any negative factors related to what we're doing. In physical activity and weight management work, we have to be very careful about sensitizing people to eating disorder issues. And since I work with a lot of young adults, that's an issue. And in our very first randomized controlled trial with college students, we found for the women only a significant intervention effect increasing body dissatisfaction. And since I'm the psychologist who was doing that part of the component, I felt really bad. And I'm like, well, I need to look at those items and see what that was. And it wasn't just I'm thinking more about what I'm eating or I'm preoccupied. That would be, maybe something acceptable for somebody in a program like that. They were really pathological things. Like, I really hate how I look. I'm embarrassed to be seen in, my underwear or in the scanty clothes. There were things anyway, they were more pathological items. So this is something that when we published it got a lot of attention, and I think it's our responsibility as developers of interventions to be mindful and thoughtful about what those things might be and to assess and analyze them as well. Finally, I'd also like to echo what some people have said, that the technology components are no substitution for the human interaction, and they need to be thought of as ways to enhance it and ways to make it scalable, make it more accessible. But one of the things that a lot of administrators in colleges and universities worry about is that our students are not learning how to have good social skills. They're not dealing with conflict face to face. And I'm not at all a naysayer about technology. I'm very much an embracer of it. But this is also something that we need to think about as we're developing these interventions. I won't go into anything about all the personal devices. We've heard so much today about the wonderful things that we can do with all these different types of personal devices. I will show you this one thing, which is, it's been around for a little while, but it's pretty cool, that you can put a little standardized chip next to your plate of what you're eating and take a picture of it with your phone, and it will estimate the volume of that portion of food and the calorie count. And these are some of the technologies that we're incorporating into our interventions. And I guess my final thing would be that the social component is something that Bandura from Stanford has said for so long is an important component. And now we have all these new ways of assessing that and perhaps intervening on that, and we should take advantage of that opportunity. All this emerging evidence about how health habits might be influenced by social networks, and expanding to see where are our clients, our patients, our customers looking, where are their eyeballs, and that where they are is where we should be. And that's it. Thank you very much.